Okay. Good morning, everyone. Thank you very much indeed for taking the time to join us at Global Genes Live, a Rare Patient Advocacy Unsummit. We're very excited for our upcoming session, which is called Accelerating Rare Disease Diagnosis with AI and ML, which stands for Artificial Intelligence and Machine Learning, in case you didn't know. My name is Chris Tackaberry. I'm co-founder and CEO of CliniThink. We work in the AI space, so I'm a technologist by background, and our software is used in phenotyping, which is a very important part of the process in rare disease. However, I am not a rare disease expert at all, and I'm looking forward, as much as everyone else is, I hope, to this session and to learning a lot from our very distinguished and very interesting speakers, and I will be your moderator for today's session. Before we get kicked off, I just need to review some housekeeping notes with you, please. First, as you can imagine, there are some challenges associated with putting this on a virtual basis, and the Global Genes team have done a fantastic job helping us work through that. So all attendees are currently muted by the moderator to reduce any interruptions and keep the flow. We hope you understand why we've done that. We encourage you to use the chat function in the On24 window for any questions you have throughout the session, and the moderator team will present them to the speakers. To open the chat, please click on the blue chat button located on the meeting controls at the bottom of your screen. And if there are questions that we're not able to address by the speakers or we run short of time, we'll do our best to follow up after the program. Also, please make sure to post your top takeaways and fun moments and other observations that you think are interesting during Global Genes Live on social media, and tag @GlobalGenes for a chance to be featured on our social media channels. The official event hashtag is #2020GGSummit. Finally, we encourage you all to participate as active listeners and take advantage of an opportunity to hear from the leaders and experts we have here and ask questions of them. This program is your time to learn and find answers on critical challenges in rare disease research. And, obviously I'm biased, but I think AI is a really fascinating juncture in terms of the contribution it can make to rare disease. And hopefully you'll agree with that conclusion at the end of the session. So you saw our distinguished panel's bios flash up on the video at the front of the session, but let me now welcome our discussion leaders in person. Annastasiah Mhaka, founder of Mawumbo Life Sciences, Dr. Terence Sanger, Vice President of Research and Chief Science Officer at Children's Hospital of Orange County, Dr. Abdenur, Chief of the Division of Metabolic Disorders and Medical Director of CHOC Children's, and Sebastien Lefebvre, Senior Director of Data Analytics and Decision Support R&D at Alexion. They will each share a more complete background of themselves as we delve into the conversation. But for now, I'd like to hand over to Annastasiah to kick things off. Annastasiah.
Thank you, Chris. Can you guys hear me all right? I'll take that as a yes. Just do a thumbs up if you're on the panel. Thank you. Good afternoon, everyone. Thank you to Global Genes and my fellow panelists for a timely and critical topic today. I'm excited to be here. Like Chris, I'm not an expert per se in rare diseases, but I am very passionate about marrying emerging technologies such as AI with healthcare to drive accessible, effective, lower-cost solutions globally. Like most of you today, I'm a huge advocate for rare diseases, and I'm here today to stand with you as we jointly seek to better understand, to identify, or to apply the appropriate tools to improve diagnosis in this underserved population. I'm going to make a quote from Shire, as they boldly stated, diagnosis doesn't have to be rare, and I echo that today. So first, my task is to give us a common grounding and set context for the exciting speakers. We have some really inspiring case studies to share with you. So while we patiently await for them, I'm going to cover 4 main points. The first is it's always great to provide the patient journey as a way for people to relate to some of the tools we're looking at. Second, I'll cover the basic fundamentals of machine learning, followed by the impact of how machine learning might influence diagnosis, and then lastly, some prevailing challenges. So I'm going to walk you through a couple of slides very deliberately to do this. So diagnosis needs are huge and unmet in the rare population. And so I'd like to consider the end-to-end continuum of diagnosis from pre-diagnosis through diagnosis and post-diagnosis. Starting on the panel 1 on your left, these are current assumptions about rare diseases that are critical to the patient journey. So we believe that there are about 350 million patients worldwide afflicted with 7,000 to 10,000 diseases. 80% of these are attributed to genetics, and 70% are of pediatric onset. 50% occur in children, and rather sadly, 30% of these do not live to enjoy their 5th birthday. So before we go further, please recall that there is a huge variation amongst rare diseases, and I'm making some generalizations here to help us kick off. So much as I tried to simplify the patient's tortuous journey, this still gives you a headache, but we'll go through it very quickly to set this up. So imagine how traumatic this is for patients, their families, and caregivers. Diagnosis is a long, complex, error-prone, and stressful journey for the patient. So from panel 1, you notice that upon experiencing first symptoms, it takes patients 5 years, 8 physicians, 2.5 diagnostic errors before receiving an accurate diagnosis for diseases which can be life-threatening or clinically debilitating. So notably in the red box you see in the middle, as I highlighted there, wrong or no diagnosis leads to unnecessary and therefore ineffective and often costly treatments. While disease progresses, patients continue to suffer or treatment is delayed. So as patients go through this journey and they finally get a diagnosis, that moment of joy or relief, if we can even call it that, is very short-lived because as they progress to the next stage of post-diagnosis, there's only 5% of treatment. So during this whole process, the patients are susceptible to other conditions such as anxiety and depression. And really, as we put this together, what we're realizing is it just attests to just how complex and how little we understand about the underlying pathophysiology for rare diseases. So this put together really has impacted the availability of relevant biomarkers or biomarker signatures, effective tools to assess risk or causal factors, or to quickly and accurately diagnose patients. Again, at the end here, there is no real clear path for most patients, and this is further exacerbated by the person-to-person variation. So right now, I'm quickly going to just give a few fundamentals about machine learning and their role in decision support. So at the bottom here, as you look to see this is the foundation of our decision-making roadmap. It is premised upon selecting the right tools to help solve a well-formulated, clinically relevant problem. And this relies on the compassion, expertise, and know-how of the physician as a first step. In fact, this is the first and the last step. Let me repeat that. A physician must always be in the loop. So clinical activities, as covered in 1, generates 2 types of data. Generates structured data, shown here through the pathway A, or unstructured data, shown here as pathway B. And because unstructured data is in a way that is not machine analyzable, it needs to be converted through text processing and classification into a machine understandable framework. And that's covered under 1 prime. That then serves as an input into this data number 2. These are different types of data. In most instances, you'll see EMR, imaging, and clinical labs. But it is very advisable to include even those data that may appear unrelated, irrelevant, or inconsequential to us, because after all, machine learning unveils relationships and key patterns between patient, population, environment, etc., that may not be so obvious to the human eye and brain. So as such, you'll see people including demographic data, social determinants of health, environmental data, and other types. This feeds into number 3, the machine learning. There are so many types and techniques that we won't have time to go into today. But to appreciate the power of these tools, we only need to understand the nuances of unsupervised and supervised learning. So first, for unsupervised, you only know the inputs, which in our case may be known patient traits. We then rely on the machine that has been adequately trained, by the way, to cluster known traits with similar features. This could include classification of cases or disease subtypes. Second, supervised learning is where both the input and the output are known, and these are used to train the machine, so known traits, known outcomes. And then one can predict the outcomes for new known traits, for example, a biomarker signature to help diagnose disease or to predict disease progression and outcomes. So the ability to classify traits and predict outcomes is essential, and this is what the physicians use to augment their decision-making process, and it then becomes more purposeful, timely, and accurate. So these resulting outputs are in turn constantly fed back into the system. Remember, I said it starts and ends with the physician to increase its accuracy over time. And as such, machine learning is a continuous improvement cycle that gets smarter over time. Lastly, just to show you where my mind is, I do believe in putting the patient at the center. And I have a very audacious pie-in-the-sky goal, which is to detect, diagnose, and treat disease in the same visit. but that's very pie in the sky thinking. So for rare diseases that require up to 5 years, contracting this timeline by any measure would be a boon to our patients. So if we need faster, simpler, accurate, and earlier diagnosis to drive patient-centered effective care. Even better, for example, is to be able to diagnose or predict disease before the onset of symptoms. So one can take preventive measures or find useful ways to stop progression. So this is not without its challenges. There are many, and I would like to emulate David Letterman by showing my top 10 barriers. You can quickly read those through. We'll go into those in a little bit more detail later. I believe these are all surmountable with earnest teamwork. And in fact, we're already seeing significant strides. And my esteemed panelists are here to share some exciting, inspiring use cases where they've seen successes and some of the challenges they're facing. So I hope this gives you a good framework to, number one, relate to the patient. Number two, have a baseline understanding of what machine learning is. And number three, appreciate the power. Understanding that we're making some generalizations here, but I just wanted to leave you with this, and I look forward to hearing an exciting discussion. Thank you.
Wonderful. Thank you very much, Anastasia. That was a very skillful navigation across a very complex domain. I must admit I was struck by your use of the words compassion and earnest, actually, which are absolutely relevant, but not often heard, especially as this is so much to do with technical detail. So important. Thank you very much. So now I'd like to move on to our second panelist, Dr. Terence Sanger, who has an equally interesting and a powerful perspective to share within the context that Anastasia has laid out. Terry, over to you.
Well, thank you so much, and it's a pleasure to be part of this meeting. I really appreciate the invitation. So I'm going to talk a little bit just about the background of artificial intelligence, and it's wonderful to be able to build on what Anastasia just told us. It's important to realize that artificial intelligence and the machine learning that generates the procedures for artificial intelligence is essentially a statistical method. It's complex statistics. It involves nonlinearities that are not perhaps present in some of the more standard statistical methods, but is nevertheless a statistical method. And that, while it sounds like it could potentially be a weakness, is actually a tremendous strength, because the process of medical diagnosis is fundamentally a statistical process. So medical diagnosis is based on the idea of the differential diagnosis, and in all cases there is more than one possible thing that a patient might have. When someone comes to see you in clinic, you may have some ideas. This is the most likely, this is the next most likely. There might be 5, 10, 20 different possibilities ranked by the likelihood that that might be the diagnosis, or by other things such as the necessity for intervention in certain diagnoses. And so this is common. Clinicians are taught this, and then our job is to process more information, to think about what's the next test I need to order, what's the next measurement I need to make, what's the next thing I need to try to do. And as you do that over time, your differential diagnosis gets narrower. It starts from being a little bit broad. It could be one of 15 or 20 things, and it narrows down to 5 or 6 things, then down to 1 or 2. You're never 100% sure, but at some point you become sure enough that you can actually make intervention and treatment decisions from that. So the idea is that there's a time process, that you start with your initial information, which might be nothing more than the patient's initial complaint and maybe their age. And then as you add more and more information to that, you get a narrower and narrower view of what the likely possibilities are, until you're confident enough that you can go ahead and do some interventions. So it's important to think of this as time-based reasoning, and in some ways it follows something which is Bayes' rule, and Bayesian reasoning says that you have a prior assumption, your background information. You combine that with measurements to come up with a posterior assumption. And so it's the combination of what you knew plus the measurements you've just made that tells you what you will know next. And I would argue that the process of the way in which we use artificial intelligence and machine learning is very similar to that process. So at some level, the genomics data is the first thing you know. You're born with it. So that's where you start. And then over time, the genomics data is modified by your experiences, the acquisition of disease, the acquisition of whatever the chief complaint is the combination of the experiences plus the genetic information, plus the treatments that happen, plus time. And so over time, there's more and more information that becomes available that allows you to combine that with the genomics data. So you start out with your genomics data, and then you may add things which could be metabolic measurements. They could be observations. What are the actual symptoms? It could be routine laboratory studies. It could be imaging. It could be something with a history. It could be including information from other family members. And as you incorporate that over time, that information becomes, again, more and more precise about making a diagnosis. And the problem now is that there is so much of that information available that it's very hard for humans as clinicians to access the thousands of pieces of information. Now, we access the top 5, 10, 20 pieces of information, but there may be what happens from number 21 to number 1,000. Well, we don't use that, and we do a pretty good job, but maybe not a perfect job of narrowing our differential diagnosis as fast as we could. And so I think one of the key roles of artificial intelligence and machine learning is the assistance in that process, taking all of the available information, every chest x-ray, every MRI, every liver function test, every piece of an equivocal metabolic test, an amino acid screen or an organic acid screen, every variant of unknown significance in the genome, and pulling all of those together to try to narrow the differential diagnosis, not just the things that the clinician can keep in their head, but that all of the information gets pulled together, and that assists the clinician. Again, it's for narrowing the differential diagnosis. It never makes a decision. It just assists with decision making. And I think this is a very important point that was made early on. The clinician is always in the loop. You can't get rid of that. Human decision making is very, very good. We're very good at this, but we're not very good at incorporating tens of thousands of pieces of information into those decisions. We're very good at taking smaller pieces of information and making rational decisions out of the data that are available to us. And so the power of the artificial intelligence machine learning technology is to be able to allow us to make decisions based on much broader set of data. It's as if you suddenly take your narrow view of the world and you put a wide angle lens onto it. You can see all of this information. And now from that, you can make a differential diagnosis. And so that's where I really think the power of these new techniques can be used in a way that mimics the thought processes and the logical decision making that goes into clinical medicine, the process of the differential diagnosis as a Bayesian accumulation of data. It's just that now we can use more data faster to get more and more accurate diagnoses. So I want to stop there and pass this on to the next speakers. Thank you so much.
Terry, thanks very much for that. Again, it's a brief but fascinating insight into the power of some of these new technologies. I can speak from my own experience there, just the wonder at what these machines can do. As you say, dealing with every piece of data and vast numbers of data points. However, I'm going to put you on the spot. We've had a question from one of our attendees, and it sort of it underlines what a mixed audience we have. So can you please give us a simple definition of or explanation of machine learning before we move on, please?
So learning itself doesn't have a very clear definition and is defined differently in different contexts. The field of machine learning can be thought of as the idea that a machine that changes its behavior based on experience, and what a machine's experience is data. So machine learning is fundamentally the process of receiving data in sequence, a sequence of data points over time, and incorporating that in such a way that the machine, the computer, changes its behavior as a function of that, hopefully in a good way. Machine learning, you can learn badly, right? But hopefully you learn to do whatever it is you're doing better. And so if you have a system that can do that, it means that a programmer doesn't have to program the actual solution. You just have to program how to learn the solution, so that you have to show the machine how to learn, but you don't have to show it the answer. For instance, you might not have to teach a machine how to analyze a genome and come up with the most likely diagnostic categories from that. What you could do is you could show the machine examples of professional geneticists doing the same process, and you could let the machine try to say over time, what are these geneticists doing? And again, it's just a statistical process. It's going to say when geneticists see this genome, this is what they tend to say. And it can just essentially replicate that. But it can replicate that from thousands and thousands of examples. So you could take every genetic diagnosis that's in your medical record or in the medical records of thousands of hospitals, and you could take every genome on which those diagnoses is based, and you could take all of that information and feed it into a machine, and it could use that to learn how to do this thing. So the programmers at the beginning just write a program that tells the machine how to learn. But at the end, the machine has learned something that the programmers themselves might not know how to do.
Well done. Thank you. Sorry for the curveball. Well, I'm not really, actually. It was great. Great answer. Thank you very much. Hopefully that was helpful to the person that answered the question and everyone else. Thank you, Terry. Right.
Of course.
So now we move to our next panelist, who's also working on a front line, but a different front line. Sebastien is working on the pharma side of this collaboration in the rare disease space, and I'm excited for us to hear his perspective also on some of the things that have already been raised in the session. Sebastien, over to you.
Yes, welcome everyone. Sebastien Lefebvre, Senior Director of Data Science at Alexion. Spent 20 years in pharma, focused on decision support, and I've had the great opportunity to work closely now on rare disease diagnostics and treatment plan for cases in the NICU, working closely with Dr. Kingsmore at Rady and Alan Beggs at the Menton Institute. So just briefly introduce Alexion. So a global company, about 3,000 employees. We do have 5 approved therapies, and we're covering 6 rare and devastating conditions. We serve patients in about 50 countries. And at the heart of our approach is serving the patient, and the work we're doing to help the NICU set up and diagnose all rare disease kids is an example of that. So I'm not going to repeat what has been said. Annastasiah and Dr. Sanger have done a great job at highlighting the issue. From a data science perspective, we'll look at the challenge of a patient presenting itself and being onboarded in the NICU and its discharge from the ICU, right? We see this as a great data science problem to solve. Data is at the heart of it, and we need a hell of a lot of analysis to be done to help digest all this information and map it against the world of 7,000 to 12,000 rare diseases. So I've mapped the process here. It's a little cartoon, but there are 2 races going on, right? At least in the NICU. Get to a diagnostic and get to a treatment plan. And as Annastasiah pointed out, there are really 2 different things. Once you've got the diagnostic, getting to the right treatment plan, especially for a neonate patient, right? Because a lot of approved drugs are not for neonate, they're approved for adult population, right? So getting to the right treatment plan is essentially, at this point, targeting what we call precision medicine. So the first part is differential diagnostic. Dr. Sanger talked about this at length. And then the second part is making sure that we have the right treatment plan for that therapeutic subgroup that the child may be part of. So where does AI help, right? And again, it's been highlighted in previous speakers, but essentially we need to start with a patient representation, right? A common one. So we can compare the patient to the disease signature, right? But we can also, and as it has been proven at the Imagine Institute work in France, in Paris, is that you can compare patient to patient. So you have an unknown diagnosed patient and you have a diagnosed patient, so you can compare their signatures, right? And so what is a patient signature? Well, it's the genotypic signature, your variants in your genome, but also the phenotypic signature, which is how your disease represents itself. And having a common representation of both, right? And then mapping that against known pathogenicity and ranking that against all known rare disease. And the same thing for the phenotype. You can go ahead and map that to the signature. And then if you combine all this information together, phenotype and genotype, you get even a better ranked score. We've talked about Bayesian, we've talked about NLPs. These are all techniques that are being AI-based that are being enabling that. Specifically on the provisional diagnostic space. So imagine you get a rank of 50 rare genetic disease, 50 gene-causing disease and related disease as provisional diagnostic. How do you apply differential diagnostic to 50+ options, right? You provide an insight for each of them, like next step. Here's a confirmatory test. This is autosomal recessive. You may want to look at the parents' genetics, so on and so forth. Some of them have diet as a treatment. Some of them have very basic supplement as a treatment, so very low risk. And then you've got that for 50. Now you can then condense this, synthesize this further, and help prune the decision tree with the best next medical intervention. For example, out of the 50, you may have a couple of those that are going to have severe degradation in the condition within the next 48 hours. You may want to pay attention to those. Or as I mentioned earlier, some of those are simple low-risk intervention that you may want to try out, right? So that kind of concludes my point here, which is essentially AI is helping every step along the way by bringing this data, providing a common signature, and then comparing, contrasting with the known knowledge base of rare conditions. Thank you.
Excellent.
Chris.
Thank you very much, Sebastien. Very exciting stuff. Again, from a personal perspective, having clinically was involved in some of that work, it's very, very exciting to be involved in a process where you can use some of these approaches to reduce tasks that might tie up a physician for long days or even weeks in the diagnostic process down to hours or even minutes. Very exciting progress. Thank you for that. And so lastly, in this first set of kind of introductory presentations from our panelists, I'd like to hand over to Dr. Jose Abdenur, who can sort of tie it all up for us in a beautiful case study, which I know you'll find very interesting. Jose, over to you.
Good morning, everybody, and thank you for having me here today. I am a clinician. I am the one who, as somebody said today, where everything starts and where everything should end. So I'm happy that I'm going to keep my job for the next few years. As I've been working with rare disorders for more than 30 years, I have experienced how we were doing this in the past, how we are doing it in the present, and how we are trying to approach rare diseases in the future. So to illustrate that, I would like to drive you through a family that I took care of. It's a family of 4 children who were born in Southern California. They developed symptoms in infancy of developmental delay, regression, rigidity, and they had difficulties swallowing. 3 of the boys were affected, and the 4th one was not affected. Of course, at the time between 2002 and 2012, we performed very extensive testing in blood, in urine, in spinal fluid, muscle biopsies, MRIs, and even the available gene panels at the time, which were not very many. Until in 2012, we saw the light at the end of the tunnel with the availability clinically of whole exome sequence. After doing the whole exome sequence for this particular family, no gene was identified. And that was for this particular boy who later on died. We continue working with the family, and that it's important to develop a trust with the family to continue them being engaged despite the not very good outcome. And then over time, we did a whole exome for the other two siblings and even for the unaffected sibling and the parents, and we couldn't find any answer through commercial laboratory. Partially because of that, partially because we were dealing with the same issues over and over again, we were able to establish a research laboratory here at CHOC. And in that laboratory, reanalyzing all data, we came up with a suspicion of one particular pathway in one amino acid that was veiling. Based on that, I asked our Ph.D. to reanalyze all the data in the exomes of the whole family members, all family members. And we were able to come up with just one mutation, only one variant that did not absolutely explain the disease. But we were sure, based on all the other pieces of information, that this information was the leading clue to for a final diagnosis. Between 2014 and now, we moved very fast. And by collaborating with other laboratories in the Netherlands, in Australia, we were able to confirm the diagnosis at the enzymatic and the biochemical level. And that was enough for us to at least begin an experimental treatment, an experimental protocol that over the last few years resulted in improvement in the neurological outcome of this family. But we didn't have the second mutation, so we continued searching, and was only until we were able to analyze the transcriptome, which is the mRNA data, that we found a silent intronic mutation that explained fully at the genetic level what we were seeing at the clinical and biochemical and enzymatic level. So we were able to put together all the pieces of information, and after that, develop some population studies that uncover that one of the mutations is common in one particular ethnic group, and we are now able to help many, many families. So as I reflect on this story, I could take it, as a success. We came up with a relatively rare disorder, found mutations, found biochemical data, published, helped families. But when I see the 10 or more years that took us to provide a diagnosis to this family, I feel really that this is not a success. This is really something that we need to improve, we need to fix, and is exactly what Anastasia was talking about before. So what are we doing today? What is the present, at least in a center that can have some research component? We have all the clinical information, and hopefully we will be better in analyzing that information through machine learning and artificial intelligence. We can do the imaging, MRIs, MRS. We can do the biopsies, the pathology, and have them analyzed also by objective machine learning and artificial intelligence. We can have the biochemistry. We can measure thousands of different metabolites in blood and in urine, and we can definitely look at the whole exome and the whole genome. We do that now routinely, and also we are routinely doing a transcriptome analysis in all families for whom we cannot have a diagnosis. So you can say this is comprehensive and we are doing great, but after doing all that, I still have approximately 40% of families with no diagnosis. So the work is not enough. And there are issues or domains that we are not being able to include in our analysis, like the epigenome, the microbiome, or the proteome, and of course the importance of environment as it was mentioned today. So it's still very far from perfect, and our results show that we are still failing our families. So the way we do it today is we have, as it was mentioned before, an avalanche of information coming to us physicians. There is no way that we can handle all that information. As Dr. Sanger mentioned, we can look at the first few papers every week or every month, and there are thousands of other publications that are flying under the radar. So with that information, we try to make sense, and we are not succeeding. Manpower is not enough to do this. So where do I see the future? And here is the future. All the scientific information will have to go through artificial intelligence and machine learning. And the way I see that is that the artificial intelligence and machine learning will not be applied to each of these domains individually. We have already some examples of good platforms that can do that. But they will have to eventually develop a language that can share and exchange information among the different domains and provide us, the physicians, hopefully with a final answer, and then in that way we can provide an experimental treatment for the families. So I hope I've been able to give you a perspective of a couple of things. It has been a very difficult ride for the families and for us physicians working on this field. It is better, but definitely not good enough. And we hope in the future that AI and machine learning will help us reach there faster. Thank you.
Thank you very much indeed, Jose. Again, a fascinating perspective, past, present, and future. As a former practicing clinician myself, I'm pleased to see that in that map of domains you have, the clinical one is still the biggest. And I think what you've said, I don't think there's any danger of physicians being automated out of this process anytime soon. Not least because, as Anastasia puts it, I don't think computers can be compassionate or earnest, or experts actually. We're getting a ton of questions, so I'm going to dive straight in, and I think I'll ask each of the panelists to give their view on this. We've had this question from quite a few folks. So why is there an emphasis on applying this kind of approach with newborns? A couple of folks in the audience are asking, when many patients don't show symptoms that early. Now that may or may not be a controversial statement. I'll leave that to the panelists to discuss. Since you were speaking last and you have a pediatric practice, Jose, would you like to take that one? Why is there an emphasis on applying this with newborns when patients don't show symptoms that early? Is the question as the way they've put the question?
Sure, I'll be happy to try to answer that.
Thank you.
Indeed, we are applying intelligence and diagnosis very early in newborns through two different ways. On one side, we have what we call the newborn screening program. And when I began practicing in the 70s, 80s, newborn screening was only available for 3, 4, 5 disorders, depending on the country and depending on the state. Today, we have approximately 60 different disorders that we can diagnose with just 2 or 3 drops of blood in a filter paper. So that technology has a lot of power and has increased our knowledge. And there is artificial intelligence involved in all that process as we get better to analyze the different markers and make sense of who could have or who couldn't have a disease. So we work on that every day, and 1 every 700 newborns today are diagnosed with a genetic condition before the symptoms appear. So that is being done and is very powerful. The other way we are doing is targeting the newborns who end up in the pediatric neonatal ICU or in the pediatric ICU, and they have symptoms and biochemical abnormalities that we cannot explain. So we are doing what we call rapid genomes, and we are collaborating on that with Ravis, and we can have in 3 days a rapid genome result. So that is very powerful. It has shown to be very important, change the decision making. But as I said before, in 40% of the cases, we are still empty-handed, so there is more that we can do.
Yeah.
Maybe I can add to that as well. I think Jose's point is very well taken, which is the early diagnosis and the potential for intervention. There's another category that's important, I think, which is children in whom you may know the diagnosis. So I'm a child neurologist and frequently might be called for a child who is having seizures in the neonatal intensive care unit. And those might be due to a hypoxic injury, to a known acquired injury. But the response to the anti-epileptic medications and the potential other complications that the child could have are going to be strongly influenced by their genetic makeup. That's the substrate against which the disease is applied. And so there will be clinical decisions, optimization of the clinical decision making, even when the genome does not provide the underlying diagnosis, even for an acquired diagnosis. The underlying genetic makeup of that child will be potentially a very strong factor in medical decision making. So I think there is tremendous use for this. This is something we're going to learn over time. We have not had access, broad access to full genomic data until very recently. And I think the impact of this on medicine in the neonatal period and afterwards is going to be tremendous.
Okay, great. Thanks both very much indeed. Hopefully that's an informative answer to the people that put that question. So in the interest of time, we've only got a few more minutes. We've got a ton of questions. So I'm going to attempt to put two questions together. It's on the theme of data. And I think, Sebastien, heads up, this one's coming your way. So we have someone asking, we work with data that is structured differently across different ecosystems. We saw those ecosystems in Jose's presentation. What are the challenges related to harmonizing that data? And as a kind of follow-up, are there any initiatives to create large shared training data sets across rare diseases, health systems? I've sort of picked you at random, Sebastien. The question is, how are we harmonizing data across different ecosystems, and what initiatives are there to create large shared training data sets across the rare disease space?
I'll have a crack at it, but I hope others will join. So first of all, let just be, at least from a decision support standpoint, in our experience, we're following the oncology playbook, right? This is bottom line, which is, helping diagnostic through data and mapping, if there's a genetic signature, a phenotypic signature, mapping it to a knowledge base that we know. There's this thing called Foundation One. Oncology, they'd share the data. In rare disease, we don't do as much. And so it'd be great if there was a way to represent rare disease symptoms and overall representation, including the genetics, into a consistent format across the board and be able to share those. And you can do it de-identified. You don't even need to identify the patient. You can actually say, this is what it looked like phenotypically, this is what it looks like genetically, and these are the diagnostic that we ended up making, and these are the treatment options, and this is what worked, didn't work. It's not complicated from a technology and data standpoint. It's everything else in between that gets in the way, but it's not that complicated. So that's my 2 cents. Anybody else want to join?
Yeah, I'm just going to add on to the extensive knowledge bases where people are coming together to provide information. We have standard vocabulary starting to be put together by groups like SNOMED or OrphaNet. and that's obviously key to simplify the nomenclature so that the data is exquisitely curated and interoperable. I also know of groups in Europe, RD Connect, and I'm happy to provide this offline, and the European Joint Program on Rare Diseases that are all trying to do this. And I think the complex nomenclature is a key one, and the coding systems within the health systems and how varied that is. So in essence, what we really need is some sort of standardization around that, and then an ability to share that data while it's privacy preserved. And some of us are working on some privacy preservation methods to allow that sharing. And the one thing I just want to add, Chris, is we actually have to learn from rare diseases, because in the future, all the diseases, because of precision medicine, are going to be rare. So they're going to have a very dispersed geographical population and all these issues. So really, we should be looking at this as a learning point and a proxy to help us as we advance precision care. So I think all these initiatives are worth looking into and understanding in a better way.
Thank you very much, Annastasiah. I actually have the next question mark for you as well, because you called it out on your flow chart. From Jason C. How are proprietary and narrative text structures of health records a barrier to ML AI? Will this be a barrier? Now, I think I heard Sebastien say those are not going to be barriers. So maybe there's a difference of opinion on the panel, but your reaction, please. How are proprietary narrative text structures of health records a barrier to ML AI?
When you say proprietary, I mean, I assume this is hidden, so it's not going to be accessible. So when we talk about NLP, it's the same thing. It's there, but it's not machine analyzable or understandable. So I call what you're referring to as hidden data, and that has to come out. And if it doesn't come out, we learn less. And I think a lot of people are treating their data like gold, and they're overvaluing it, and maybe they're right, maybe they're wrong. But in the future, we're really going to keep seeing public data sets intermingled with those proprietary pieces. But for those public ones and accessible ones to be strong and viable, people do need to give up something. So I think we're going to see more business models around sharing of data and monetizing it.
Got it. 100% agree with that for what it's worth. Thank you. Okay. Moving away from some of the technology aspects directly and data aspects, which of course are crucial, we have another question. What would the impact on cost of diagnosis be here if the sort of future state that we're imagining were a reality? Would there be a reduction or an increase in cost? I think we all know what we want the answer to be, but what do people think? Does any of the panelists want to have a first shot at that?
I can.
Please.
Sorry. I can comment on recent studies that are being performed by Ravis, looking at interventions in newborns or sick babies in the pediatric ICU who received an early diagnosis versus a late diagnosis, and the early diagnosis facilitated by whole genome sequence versus the late diagnosis done in different ways. There is evidence that there is savings in the healthcare system. You do less procedures, less wrong medications, less interventions, and sometimes the information allows just families to make the right decisions at the right time. So that data is not yet published. I know it's in the process of being written, but I think that will be a very powerful piece of information. in general, we all think that earlier diagnosis saves money. And that has been the experience of newborn screening over the years as well.
I think the hope is that obviously you're doing a test that you weren't doing before, so there's an increased cost to performing the new tests. But the hope is that that will reduce back-end costs. If you have a precise diagnosis, if you have a genetic diagnosis, you can stop doing the MRIs, you can stop sending other single gene tests that you might have been considering sending, you can stop doing other types of diagnostic issues and start concentrating on therapeutics. Hopefully that would reduce costs in terms of better efficacy of the therapies, better health, and less expense associated with that, as well as reducing the other types of tests that might be needed.
So I think the message appears to be that regardless of the actual cost of the diagnostic procedure, doing so early has massive downstream savings. I think that's the consistent theme, and hopefully that proves to be the case. I think there's a paper that Stephen Kingsmore already published now 2 years ago in Nature that did actually look at some of the initial potential savings, as well as the more recent work that hopefully will be published soon. So that's definitely worth a look. We've got a specific one, if I can find it, for Sebastien. I'm just sorry for the wait here. I'm scrolling up. So there's a question which says, question for Sebastien from Sarah D. Are the pharmacogenomic data being included, P450, CYPs, etc.? Lots of rare disease kids on many meds, not used. Not many are looking at PGX. Sebastien,
so
how do you respond to that?
Yeah. So obviously part of the decision support approach involves us we have built essentially a very exhaustive and extensive rare disease knowledge base, which does include counterindication for drugs and comorbidities and so on. And so we do have the data, but we also are curating evidence around those pharmacogenetic endpoint, and also we are getting some of that stuff medically reviewed. So it's always about enriching the knowledge base from all potential dimension, and then feeding that as an insight for each provisional diagnosis.
Thank you. Thanks very much. I hope that answers the question. Okay, we've got 2 minutes left, and I'm actually going to go around the panel and ask each of you what I think is a very topical question, and as me and my company have been involved in this space, it's something that we're wondering and looking to the experts in terms of their perspective, and that is, do we see and do we think it should be the case in the future that all newborns should receive whole genome sequence screening as a matter of routine? I'd like to go around each of the panel and just get a brief answer to that, please. Anastasia, let's start with you.
Chris, you had to start with me. That's a tough one.
Alphabetical.
So, yeah, and I'm not a pediatrician by any means. I don't believe that testing for the sake of testing is good. But we are starting to learn more, and as long as what we learn is actionable from a clinical standpoint, and we can demonstrate that it leads to better outcomes, etc., I think we go ahead and do it. The compassionate side of me says, of course, yes, but the practical side says we need to make a compelling case so that we get buy-in, because it will cost some money.
Okay, so let me, in the interest of time, we are in the last minute. Do any of my panelists disagree? The panelists disagree with what Anastasia said?
It all depends on cost. If the cost of a whole genome is under $10, of course you're going to do it. If it's $1,000, you're going to have to look at a cost-benefit analysis. But the only thing we know for sure is that the cost is going to decrease over time. So at some point, when the cost of the genome sequence is less than the cost of tandem mass spectrometry, then perhaps the reality will be that, in fact, it does make sense to do this on everybody, and maybe perhaps even substitute for some components of the current newborn screen.
Thank you, Terry. You had the last word. We are now out of time. It just remains for me to say thank you so much to all the panelists for leading such a great discussion. We can hear the passion for the subject and the space and the cause, which is great. Thank you very much to the audience for your questions, which were very thought-provoking. Please join us for either Elevate Natural History, Study Planning and Reach, or Communication Tools for Accessible Science coming up next. Thank you very much for participating.
Thank you.
Thank you.
Thank you.